So, good morning, everyone, and thank you very much for inviting me to this important conference to share some of our experiences regarding the HPV type-specific cervical cancer risks and how we have tried to use this information to optimize the cervical screening programs. This is a slide that is probably very well known to most people in the HPV field. This is a joint analysis of 4 randomized HPV screening trials in Europe, where one of them was our trial from Sweden. But the basic fact that is shown here is that the protective effect against cervical cancer was in the trials about twice as good as that of the cytology screening, and that there was a huge difference in the risk for cervical cancer if you tested negative for HPV compared to if you tested negative in cytology, and that it lasted much longer. The better cancer protection was particularly prominent for adenocarcinoma. We had this paper as a basis for the decision that was made by the government of Sweden in 2015, just a year after this study was published, that Sweden should switch to HPV-based cervical screening. However, this was implemented only very slowly, and it was fully implemented only 6 years after the national government decision. One thing that was quite clear during these times, when cytology was still in use in Sweden, was that the difference between HPV screening and cytology screening was considerably larger in real life than what it had been in the trials. In this table, you can see the number of invasive cervical cancers after a negative cytology to the left and after a negative HPV test to the right. And you can see that the difference is even very much more striking when comparing how cytology and HPV testing is used in real life. So we can say that we've had a long journey. It is now 34 years since the first HPV test was FDA approved, 20 years of collecting evidence from randomized trials, many years of discussions on how to use it, and then after the government decision, still some delays before it was actually used. But nowadays it is actually fully used, at least in Sweden, and I hope in most other parts of the world as well. In Sweden, we have today switched to self-sampling in the primary HPV screening, and it's seen also that a lot of countries are doing this switch, and we have also switched to using so-called extended HPV genotyping in the primary screening, which is a practice that is also spreading around the world that I will be describing. Actually, a lot of this came about because of the COVID pandemic. In April 2020, we had a severe outbreak of COVID in Sweden, resulting in that all non-emergency healthcare was cancelled, including the cervical screening. In June 2020, the outbreak had subsided and the program was allowed to restart, but there were prohibitions that the screening stations must not be crowded to avoid spreading of the infection. So we basically had only one possibility to perform the screening in this circumstance, and that was a rollout of primary self-sampling as the screening method instead of physician-taken smears. It had been discussed for decades, but now when we were forced to do something else, then it was finally implemented. Self-sampling is possible only if you use HPV testing, and all regions now finally switched to HPV-based screening throughout Sweden, and we use it now in all ages starting from 23 up to 70 years of age. This has actually resulted in a huge reduction in the costs from the program. 10 years ago, we were asking all the countries in the European Union if we can give the exact amount of money that we pay for the program. Actually, only one country could cite how much they paid. And it was interesting that they paid more than twice as much in fee to the sample taker compared to what they paid for the test itself. And then with the self-sampling, the costs are at least 10 times lower than these fees to the sample takers. Other thing that was most interesting and much more than we expected is that it greatly increases the population coverage of the screening. This shows the population coverage of cervical screening in the greater capital region of Sweden, where we had been working persistently for many years to increase the population coverage of the screening, and it came up to 76% in 2019, dropped a little bit during COVID, but then when the self-sampling was launched in 2021, it jumped up by about 8% in just 1 year, and it's now over 80% of the population that has participated just 1 year after we introduced this. The other thing that is a major subject of my talk is the extended genotyping. We are working towards a maximally effective and convenient screening program. Currently, we and most other countries are using a strategy that's called one size fits all, where the entire population is summoned to screening at regular intervals. But actually, determinants of risk are well known, and could those be used to improve the screening strategy? Apart from one risk determinant that was well known before, which is screening non-attender, we used the National Screening Registry of Sweden to identify 3 other identifiers of risk. It was women who had had glandular atypia, or women who had had a high-grade or low-grade cytological abnormalities without adequate follow-up, which was particularly dangerous above the age of 50, as shown in this slide here. To the right is the exact number of women with this profile resident in the country of Sweden. One interesting thing that I would like to point out is that we have actually only 29,000 women in Sweden who absolutely never attended a cervical screening. The population coverage that I showed before are the people who always attend according to recommendations, but also a large part of the population are sometimes attenders, and actually the never attenders are quite few. The other factor that, apart from screening history, is now abundantly clear and is being used in the programs that has recently been launched is the different cervical cancer risk by HPV type. This has actually been known for decades. This WHO IARC study is 8 years old, but it's based on about 44,000 cases of invasive cervical cancer and several 100,000 samples taken from healthy women. And then if the different types are listed here, you can see that it's HPV 16 in red, increasing the risk for cervical cancer by 48 times, contributing more than 60% of all cervical cancers, followed by the types in orange that increase the risk for cervical cancer between 8 to 16 times, and then the types in yellow that increase the risk from 2 to 7 times and are targeted by vaccines. The other types lower in green and blue contribute very little to the risk of cervical cancer. For example, you can look at HPV 51 in the green area, where you can see that it increases the risk for cervical cancer only 1.2 times and is responsible for an almost negligible amount of 0.2% of the cervical cancers. This is depicted in the pie chart to the right, where you can see that it's the red, orange, and yellow types that is something to worry about, not the green and blue ones. And it should be remembered that if you do HPV screening in a population, The green and blue ones are more than half of all positivities in the test. Another problem with the screening programs is that most women have almost no risk. Most women always attend to the cervical screening and always have normal smears. Those women have a risk reduction of about 80% with cytology, probably even lower if they are always HPV negative, and they are the vast majority of the population. For example, we have a target population of women in Sweden that is about 3 million women, but about 2 million of these women are always attended with always normal screens and that really don't need any more screening. That's a challenge. Several million women who don't need it are screened. We don't have any particular priority to the small number of women who have high cervical cancer risk. And with the advent of HPV typing data, the risk differences that are now on file in the screening registry are now several thousand-fold, ranging from women with HPV 16 in a glandular atypia, with a risk of cervical cancer of 17%, to the women who are always HPV negative, which have a barely measurable cervical cancer risk. It's also an ethical problem that the results on the risks are not clearly conveyed to the women. It's mostly conveyed that the screening test was positive or negative, and that is definitely not the whole picture. So to assess more in detail how this was affecting the risk, we genotyped all the cancers in the country during 10 years. We started with the cancer registry, requested the archival pathology blocks, did PCR and whole genome sequencing on those. Could be completed for almost 3,000 cases. And then we had the complete screening history of all the cases that was retrieved from the Swedish National Cervical Screening Registry. And genotyping in the population was either from the screening registry or from a national population-based HPV screening trial, the one that I mentioned in the beginning. This is the percentage of HPV positivity in the population from an excerpt from the screening registry. Yellow is all HPV types, and you can see that the 95% confidence intervals are very small. This is about 500,000 women in this excerpt. They're only a little bit wider when it comes to screening below 30 years of age, because it hadn't been recommended at that time. Then you have the HPV 16 and 18. You can see these are just a few percent. And then there is a large majority of all positivities for HPV that are so-called other HPV types. This was done at a time when we were not using extended genotyping yet as we are today. So we used this, complemented it with some complete typing data and calculated the numbers needed to screen and numbers needed to follow up for a screen detection of a cancer. As you know, a screen detected cancer has much better prognosis than a symptom detected cancer. You can see, for example, if you would like to detect a screen detected HPV 16 positive cancer, you need to test about 14,000 women and do about 400 colposcopies before you find one. Some other types have so low risk that it's not possible to calculate how many colposcopies you need to do. It is infinity. But cervical screening is not only about early detection, it's also about prevention. Any screening participation during the last 10 years could have identified and treated a precursor. This can be readily quantified. We know the incidence among those who never attend, and we know the incidence in those who do attend. This is the age-standardized incidence rate of invasive cervical cancer in Sweden by screening status in the last 10 years. In the red is the risk for cervical cancer among the women who are not screened at all, and then the screened women are the green line that is lower, and then all women in the country is the purple line in between. Then the preventive effect of a screening program is the red line minus the green line. And then we know all the data regarding prevalence among the controls and the cases, and we know the preventive effect. So it's very simple to calculate the numbers needed to screen and the numbers needing follow-up for prevention. So if we again compare here, we can see that in order to prevent a case of HPV-16 carrying cervical cancer, you need to screen more than 5,000 women and do 147 colposcopies. If you would like to prevent a case of HPV-59 carrying cancers, you need to screen 2.5 million women and do 9,000 colposcopies. If we also consider age, the data becomes even more striking. I can give as an example in this little bit busy table on numbers needed to screen for detection, prevention, and numbers needed to follow up for detection and prevention. If we look, for example, on HPV-16 in the lower table to the right, you can see that in order to prevent a case of HPV-16 carrying cancer among women above 50 years, you need to do 58 colposcopies. If you would like to prevent a case of cervical cancer carrying any one of the lower oncogenicity types, the 7 types listed in the bottom of the slide, you need to do more than 17,000 colposcopies before you have even any measurable benefit at all of this exercise. Thank you very much for your attendance. The work that I have showed you was supported by the European Union contract on promoting risk-stratified screening for cervical cancer.